So this is the trend on the trend which they had observed during exercise. So the difference in wedge pressure which was there at baseline was not significant, but with exercise the difference became augmented, and the maximum difference was seen during peak exercise. Similar observations were seen in the LV EDP and the PA mean pressures. Exercises just augmented the difference between the two groups. And also there were significant differences which were seen in the difference in the SVRI, difference in augmentation of the heart rate, difference in augmentation of the systolic blood pressure, as well as the cardiac index. And so the ROC showed that the significant parameters which could exclude patients controls from patients with HFpEF were the exercise PS systolic pressure, the leg raise pulmonary capillary wedge pressure, resting PS systolic pressure, and the E by E prime ratio on echocardiogram. So again, this was like one more study. It was done from Australia as well as the Netherlands in hemodynamic basis of exercise limitation in patients with heart failure with preserved EF. Similarly, they found that at rest, the tissue Doppler velocities S prime and E prime were much less in those patients with HFpEF. The E by E prime was elevated. And they again did a cardiac cath at rest and post exercise, and they found that although at baseline there was not significant difference between the wedge pressure and the PS systolic pressure, the SVRI was significantly elevated in those with HFpEF, and at peak exercise these differences were much more augmented. So it just unmasked the differences which were not there at baseline. And this is again the graph which showed that on exercise how the parameters change and the difference gets augmented. So the summary of this entire thing of these studies are that in patients with HFpEF with exercise, RA pressure goes up, PS systolic pressure goes up, mean PA pressure goes up, pulmonary capillary wedge pressure and elevated and LV and diastolic pressure, they go up much more than patients who are normal. Mean arterial pressure also goes up. Cardiac index cannot be, the patients with HFpEF, they can't increase their cardiac index so much. PVRI and SVRI, they are not much affected with exercise in the HFpEF, but in normal patients they come down. So the rationale of a diastolic stress echo is that, again as I've said, that it unmasks the exercise related elevation of PA pressure, wedge pressure and LV and diastolic pressure in patients with normal parameters at rest. So the protocol which is followed is first you have to get a baseline echo, and then we have to subject the patient to exercise, either treadmill or an ergometer, and then we have to acquire the post-exercise echo images within 90 seconds of termination. So these are the protocols that we use. For bicycle ergometer it is 25 watts, for treadmill it's a standard Bruce protocol which is used. The parameters which are measured are the LV ejection fraction, wall motion abnormality, E and A, E prime, A prime, and the tricuspid velocity. So a positive test is indicated by 2 or more of them, that average E by E prime is more than 14, septal E by E prime is more than 15, TR velocity more than 2.8, and E prime of less than 7. For elderly patients, we have got something called a Cardiff media protocol which is used. So this is an illustrative case. At rest, the E wave is 0.6, E prime is 4, rest E by E prime is 14, RVSP is 27, and TR velocity is 2.2. Post exercise, we see that E has gone up significantly, 1.2. E prime has not increased that much. So E by E prime post exercise is 17, and peak TR velocity post exercise is 2.9. So 2 are positive. So this is a positive stress test. Similarly, in case number 2, the E prime at rest is 0.4, E by E prime is 5, rest E prime is 9, TR velocity is 2. Post exercise, we find that E by E prime is 7 and TR velocity is 2.7. So this is negative. Case 3, at rest E is 0.9, E by E prime is 10, TR velocity is 2.5. Post exercise, the E by E prime becomes as high as 18 and the RVSP becomes 57. TR velocity is 3.5. It again becomes elevated. So this is again a positive test. So this is how we evaluate a patient. Patient coming as to suspected heart failure, we do a full biochemistry, pro-BNP, electrolytes, RFT, ECG, blood count, X-ray. If we suspect heart failure, we get a screening echo done, LVF more than 50%. Then we assess the resting diastolic function. If there is grade 1 diastolic dysfunction, patient is symptomatic, we can subject him to a stress test to unmask the parameters. And the grade 2 or grade 3 diastolic dysfunction, we might still go ahead with a stress test, but it more or less tells that the patient has got HFpEF. Prognostic implication, the patient with a positive diastolic stress test has got increased risk of cardiovascular death, hospitalization, MACE, and new onset atrial fibrillation. So pros and cons of each. So basically in the We use a apical 4-chamber view to see the E and A, but the problem is with exercise, E and A tends to fuse at higher heart rate, so measurement might be difficult. PS systolic pressure by the tricuspid velocity is much easier. It is not affected much by heart rate. The AAC and the ESCVI guidelines, they also recommend a diastolic stress testing for patients who are symptomatic with grade 1 diastolic dysfunction as rest, and they are asked to measure the parameters as I have already told. So diastolic stress echo is useful in unmasking diastolic dysfunction in a symptomatic patient. The parameters have to be recorded within 120 seconds of exercise termination, and a positive test is a major predictor of cardiovascular death, hospitalization, MACE, and new onset AFib. Thank you for your patient hearing.